Well, good evening, everybody, and thank you very much for this kind invitation. So I'll be talking, can you hear me all?
Yes.
Yes.
Perfect. So I'll be talking about improving heart failure outcomes through newer implantable cardiac device technology. No relevant disclosure, but I would be using or talking about things which are not FDA approved yet. So we'll start with the case of a 71-year-old gentleman with a history of ischemic cardiomyopathy, had ventricular tachycardia, has a dual chamber ICD, NYHA class 3 symptoms, EF 25%, and has a ECG which shows atrial pacing and the kind of left bundle branch block QRS. Now, based on the current guidelines, the fact that his QRS is more than 150 milliseconds, left bundle branch block, NYHA class 2, class 3 symptoms, he would get a CRT upgrade in his situation. Now, CRTs are fun procedures to do. Normally, if you have a nice left bundle branch block, you do a CRT, the EF normalizes or does get better, and the QRS starts to look much better and narrower, assuming you have good LV lead position. I like this quote from Donald Rumsford where he said, there are known knowns, there are things that we know, and there are also unknown unknowns. That means there are things that we don't know. So for improving CRT response rates, the known knowns really are typical left bundle branch block, non-ischemic cardiomyopathy, non-apical lead position, potentially quadripolar lead placement, and 100% bi-V pacing, as we talked earlier, with a good pacing morphology, would generally be the known knowns, which is going to improve the CRT outcomes. Really, the unknown is the kind of cardiomyopathy patients have. Because CRT is not going to cure somebody from their cardiomyopathy. It may improve it a little bit, but the cardiomyopathic process is still going to continue despite the medications, despite the device, what we are doing. And that becomes kind of the unknown part, that we really don't know how this disease is going to progress. And as all we know that not all non-ischemic cardiomyopathies are the same, and certainly not all ischemic cardiomyopathies are the same, and they can get repeated insults, they can have worsening cardiomyopathy, and that could be one of the reasons why sometimes CRT causes non-response or poor response. Coming back to our patient, he came for a bi-V upgrade, and we do a venogram and his vein is completely occluded, and no amount of wiring or venoplasty would potentially save us to get into this vein. So the options for this patient with occluded veins could be a venoplasty or tunneling the lead from the right side, or potentially surgical referral for an epicardial lead. The current limitations of epicardial lead or epicardial CRT is sometimes it's just difficult to implant the lead. If somebody has had a prior sternotomy, a lot of fibrosis, adhesions, it's difficult to find a good spot to implant the LV lead. The leads can certainly get dislodged. Phrenic stem is always present. And a lot of times it's not uncommon to know that whenever these surgical leads are implanted, at some point they also get deactivated. Complication rates are higher. Sometimes you may not get the ideal LV lead position. And finally, it depends on your surgeon's mood, if he's in a good mood or a bad mood. Because if you do this procedure and you end up in the wrong location, it's certainly not going to help the patient. Now, we know that the endocardial LV pacing offers slightly more physiological resynchronization because the depolarization is directed from the endocardium to the epicardium compared to the CS pacing or lead in the coronary sinus, where the activation is going from epicardium to endocardium. And that's why there is some, a lot of interest now in conduction system pacing. The advantages of LV endocardial pacing would be increased access to sites, greater implant success, less phrenic activation, more physiological activation, shorter conduction path length, and the fact that you're in the endocardial space, you're going to have better access or more access to the Purkinje network compared to the epicardial system or in a coronary sinus where there is no Purkinje network noted. So initial interest was to actually place an LV lead through a transeptal approach into the left ventricle. And this is the largest study, all-sync, which showed that through a transeptal puncture, you could potentially place a lead on the free wall of the left ventricle. Good success rate. These patients obviously were on anticoagulation. The challenge really becomes stroke. About 12.6% did have a CNS event, either a TI or a stroke. So that certainly is not going to fly. Now, there is a lot of interest in the WISE CRT system. So just to understand this system is that the patients already have some sort of pacing device, either a dual chamber ICD, pacemaker, or even a CRT with the LV lead being turned off. Then using the existing device, you can place a transmitter and a battery, and subsequently a small electrode called as a receiver electrode is placed in the left ventricle, and I'll come to the technique of it. The idea here is that after every RV pacing, this transmitter picks up that pacing through an electrode present on this transmitter. And then after that pacing, it sends ultrasound energy, which gets picked up by this receiver electrode. And then that gets converted from ultrasound energy to electrical energy. And that's how you can stimulate this LV endocardium and have both LV and RV pacing, resulting in bi-V pacing. So very nice concept that how you could leverage the use of ultrasound energy, small electrode in the heart, and then try to cause cardiac resynchronization therapy. It's a two-stage procedure and practically a 2-day procedure. First day, we do the implantation of the generator and the transmitter. And secondly, the second day is the implantation of the electrode in the left ventricle. So generally, these procedures take a little longer time. Learning curve is a little longer. So general anesthesia, radial arc line, and initially we do like a mock prep, like we keep the transmitter outside the body because we need to find a good acoustic window. There should not be much tissue, lung, bone between where this transmitter is and the heart, because the more impediments there are, like lung, soft tissue, the less the ultrasound emission from this transmitter is going to find that electrode in the heart. So best would be to have a very, very small window where you don't have much tissue, and then the ultrasound energy can find that transmitter and then stimulate the left ventricle. So this is from one of our recent cases. It's quite a wide prep for the site. We make an incision here in the parasternal space. After marking it from an ultrasound, the incision should be big enough that we should be able to put an echo probe to identify that we have a good acoustic window and there is not much lung or other soft tissue between this and the electrode, which is subsequently going to get placed. We dissect it up to the intercostals and then place and then we can look at the prepectoral fascia, serratus fascia, and then there is a tunneling tool through which this transmitter gets placed here, the battery gets placed here, and then that gets all sewed up. So it is quite, if a lot of us who are doing subcutaneous ICD, this becomes a more doable procedure nowadays rather than just starting it off from the fresh start. So this is the transmitter. This gets tunneled here, and then you can tie the transmitter down to the bone, connect everything to this pulse generator, and that goes in this location in the mid-axillary space. Both the incisions get closed, and this is day 1 of the procedure. Day 2 of the procedure is to implant this electrode in the left ventricle, and it can be done either by a retrograde approach or transeptal approach. This is a 12 French delivery system, has an 8 French catheter in that with a balloon. This small part is the electrode. And through contrast injection, we are trying to see whether we have contact with the LV endocardium, inflate the balloon, deliver this electrode in the LV endocardium after making sure there is enough tenting, and certainly contrast can help in that. And once that position is noted, you can basically disengage with the delivery system and this electrode is deployed. Now, once this electrode is deployed, then the transmitter will hopefully emit ultrasound energy, and this electrode will convert that energy into electrical energy and cause LV stimulation. This is the final picture, a good location here. And another good part with this is that you can always check sensing as you move along in different parts of the endocardium, and you are really not limited by a choice of a vein, which one may encounter when we are doing a traditional CRT system. Intracardiac echo also becomes helpful, and you can make sure that it's making good contact with the myocardium and the final X-ray. This was the post-implant ECG. So again, you can see nice correction of the QRS which happened with this patient, and generally a good result. Some technical considerations should be that the LV electrode and the transmitter should be probably less than 10 to 12 centimeter from each other. That's only with this ultrasound energy can get picked up by the LV electrode, because otherwise if it doesn't, then you may not have good LV pacing going on. Similarly, the delay between the RV and LV is about 3 to 5 milliseconds. So you may have a lot of synchronized LV pacing with RV pacing. The limitations in today's time is there is no available remote monitoring. Battery life is about 4.5 to 5 years, and these patients need to be on some sort of antiplatelet or anticoagulation after the procedure. And as we know, most of the heart failure patients are on some medication regardless, so it is certainly doable. The size of this electrode is the size of a grain of a rice, so pretty small. And initial studies, select LV study, showed a lot of promising results, that patients who had that, about 97% had successful implants, and there was improvement in ejection fraction, decrease in the LV end diastolic and systolic volume, and decrease in the QRS after pacing. Complications rate were low but acceptable in this range in this initial report. And finally, the CRT response was overall better in this endocardial pacing compared to traditional CRT. So certainly promising. When there was a international registry looking at the complications, we started to see more deaths, because there were about 90 patients enrolled in this study. 3 procedural deaths, 2 were because of LV perforations, tamponade, and 1 was sepsis. So certainly there is going to be a learning curve, and majority of the complications happened within the first 10 cases for that particular center. So again, experience is going to help a lot in minimizing complications as we embark on doing more of these procedures. So this is one option what these patients have if you are unable to place an LV lead in these patients. Certain other things would be conduction system pacing, which I know was covered before, so I would potentially skip that. Another issue comes in patients who need a device which can do the job of defibrillation, can do the job of pacing, but there are no leads involved. So is there a way we could do that? So let's talk about this another case of a young man who was playing basketball, had fatigue, shortness of breath, has a classic ECG for hypertrophic cardiomyopathy, gets an MRI, again, lot of thickness at the apex. And actually there's a small aneurysm and a pouch now at the apex. So based on the current ACC-AHA guidelines, the fact that he has an apical aneurysm, an ICD would be a reasonable strategy for this particular patient. So when he comes to see an electrophysiologist, certainly a transvenous ICD can be given, well-validated, good history. Limitations are some lead-related complications. But this patient, again, is a young person, 41, 42. So if he's going to have indwelling leads in his heart for the next 30, 40 years of his life, certainly these things are going to catch up with him. Subcutaneous ICD can be done, but there is no transvenous lead, so that's a major advantage. But again, the generator is larger, and there is no pacing or no anti-tachycardia pacing with these devices. And nowadays, there is new extravascular ICD, EV ICD, where there is again no transvenous lead, which is the main advantage. They have a function of pacing, anti-tachycardia pacing. Size is similar to the traditional transvenous ICD, and a longer battery life. Again, this is part of a trial at this point. So we all know with conventional devices, there's a risk of pocket infection, erosion, hematoma. Repetitive movements of the lead is going to cause trauma to the leads, and that's going to cause, again, fracture, fibrosis, difficult extraction, etc. So with this extravascular ICD, it's a standard ICD. It's about 33 cc, can deliver up to 40 joules shock, can do anti-tachycardia pacing, post-shock pacing, pacing in pause, good battery time. This is the lead, which is a 9 French lead, has 2 electrodes for pacing and 2 electrodes for shock as part of this lead. There is an introducing tool or a tunneling tool by which we have to gain access and deploy the lead through this safe sheet. And finally, this tunneling tool will help to guide you to that particular location. Now, when the sensing is concerned, as far as sensing is concerned, the sensing is between these two ring 1 and ring 2 electrodes. Alternate sensing can be between the ring 1 and the can and ring 2 and the can. So you have multiple options for sensing. For high voltage pacing, again, you have different vectors which can be used. Similarly, for low voltage pacing, there are different vectors which can be used at different pulse widths. Now, when we think of implanting it, we need to understand some anatomical aspects and some anticipated challenges. So this is the anterior surface of the heart, right ventricle outflow tract, right ventricle, left ventricle. These devices are going behind the sternum. So behind the sternum, but not towards the heart. So they're going behind the sternum. So as we get prepared for implanting these devices, some regional anatomy is very, very important to know. One key part is if you are going to get access here, there is going to be diaphragm which would need to be crossed as we get here. Now, the diaphragm is almost like a shape of a parachute in this location. So at the thinnest portion here on the left parasternal space, you could by blunt dissection cross this, and then you may end up in this retrosternal space where the lead would get deployed. Certainly, cardiac CT is paramount before doing these procedures, and you would know the exact course that how you're going to go behind the sternum in the retrosternal space and not towards the heart to minimize the risk of perforation. Again, from one of our recent cases, it's a bigger prep required. You can again even do this by attaching phantom devices, so you know exactly where the location of the potential electrode and the device is going to be before actual incision is being made. We like to mark the site by having a sternal midline, so hoping that the lead goes behind that right and left parasternal space, xiphoid process, and costal rib margins. And the incision for getting the lead is going to be somewhere in this particular location. Again, fluoroscopy helps before even implanting the devices. And key thing would be to look at both a lateral view and an AP view to understand the cardiac silhouette and understand how the retrosternal space is going to look like, where the can is going to be. So at least we know that we will have a good defibrillation vector when we are shocking in this particular direction. So this is from our case here. An access is obtained, and then with this tunneling tool, the lead is deployed. It looks like this on the X-ray, and then it is connected to a device in this location, and it works out pretty well. Now, the key thing where it is really unique is that the overall DFTs are much lower in a substernal device compared to a subcutaneous device. So that's something good to know. And it's almost similar to a transvenous device. Now, with this, in addition, you have pacing capability, anti-tachycardia pacing. It does appear that this could be one of those devices which might get popular in the next few years once it gets approved. So certainly has its own unique advantages. Implant procedure is still quite tedious and arduous. And at least for the first few cases, what we have done here, we had a cardiac surgeon in the room to help us in case we have a problem doing these cases. Lastly, beyond devices, a lot of interest in neuromodulation. And we all know that this complex network of autonomic nervous system plays a huge role in sympathetic and parasympathetic involvement and effect in heart failure along with for arrhythmias. And a lot of ways these can be modulated by baroreceptor stimulation, tragus nerve, cardiac plexus modulation, renal nerve modulation, and these things can help. In future for heart failure therapy. Now, to finish off, I just wanted to show that there are so many CRT guidelines and documents about the indications of CRT. But if you look at the fine print of all the guidelines, one thing is common, that there is really no recommendations on how to follow a patient after CRT is done. So we can get a beautiful result, but the guidelines don't tell us how to actually manage these patients. And that's why it comes to the main question is, why do 1/3 or 1/4 of these patients don't respond to cardiac resynchronization therapy? Well, we don't know. Like we said, there are certain unknowns which we can never know. Maybe machine learning type algorithms may guide us down the line in a better way to try to see whether we could have better idea about who is going to respond. And if somebody is really not going to respond with high comorbidity burden, frailty, etc., then maybe they might not be the right patients getting CRT despite qualifying by guidelines. So whenever there is a new technology going on, at least in current era of social media and Twitter, whenever in the pre-hashtag era, if there was a jump off the cliff challenge, nobody's going to jump off that cliff. But in a post-hashtag era, if there is a hashtag jump off the cliff challenge, people are going to start jumping. The point being made is that really for these new technologies, before we try to adopt them and use them in our practice, we have to be clearly aware of uses, limitations, complications, anatomical, physiological challenges, and then we should try to embark on trying any of these new technologies. So in conclusion, newer technology is certainly on the anvil to offer resynchronization options. Future innovation, I think, will likely focus more on leadless options and autonomic modulation. And certainly artificial intelligence, machine learning may help identify the feasibility of CRT for a particular patient. So I'll stop here and thank you very much.